Assalamu alaikum. I'm Professor Dr. Haidar Jawad Mubarak. I will present some aspects about the peritoneum. The peritoneum is a membrane lining the abdominal wall and covering the abdominal viscera. And therefore, if you consider this figure, this diagram, that shows a sagittal section into the abdomen. Here, this is the diaphragm, and here is the pelvis. This is the anterior abdominal wall. This is the abdomen, and there must be here posterior abdominal wall or vertebra. From this diagram, you can see that the membrane of the peritoneum is divided into two parts. Parietal peritoneum, which is the peritoneum lining the abdominal wall. For example, this one, this green line lines the anterior abdominal wall, so it is parietal. This is a lining or covering of the floor of the pelvis. It is parietal. This is a peritoneum of the posterior abdominal wall, so it is parietal. Here is the diaphragm is covered from inferior aspect, so it is parietal peritoneum. The other part is the peritoneum on the liver, on the stomach, on the intestine. This is a visceral peritoneum. So, details of these two layers of the peritoneum includes that regarding the parietal peritoneum attached to the anterior or posterior abdominal wall, superior or inferior, the parietal peritoneum is not firmly adherent to the anterior abdominal wall or posterior abdominal wall, and is not firmly adherent to the floor of the pelvis or the diaphragm. It is loosely attached, the parietal peritoneum is loosely attached to the abdominal wall, and actually it is attached to the abdominal wall by a loose tissue which is called extraperitoneal connective tissue, and this point is very important in regard to surgery, because sometimes you need to do an operation for the kidney. This is drawing for the kidney. You can approach the kidney by an incision from the back, in which you will able to do an operation of the kidney, which is covered anteriorly by parietal peritoneum, and for example getting stones from the kidney and get out without entering the or without rupturing the peritoneal wall and without entering into the peritoneum. This is one thing. The other thing, that the parietal peritoneum that lines the abdominal wall, the posterior abdominal wall, anterior abdominal wall, the diaphragm and the floor, this parietal peritoneum is supplied by the same spinal nerves, which are somatic nerves of the anterior abdominal wall or of the posterior abdominal wall, of the floor and or the roof, which is the diaphragm. So this parietal peritoneum is pain sensitive. It is sharply sensitive to pain because it is supplied by spinal nerves. While comparing these criteria with the visceral layer of peritoneum, we may say that the visceral layer of peritoneum is very firm adherent to the organs. It is adherent to the liver, adherent to the stomach, adherent to the intestine. You cannot separate the visceral layer of the peritoneum from this organ because it is firmly adherent to them. And the visceral peritoneum is supplied by the same nerves of the viscera, which are autonomic nerves, sympathetic and parasympathetic, and therefore they are poor sensitive to pain or vague sensitive to pain. The space between the parietal and visceral layer of peritoneum, here in this diagram the visceral is in a color which is different from that of the green, purple it is here, while the green is parietal. The space between the parietal and visceral layer is called peritoneal cavity, and actually it is not really a cavity, just it is shown in this figure. It is a potential cavity. These parietal and visceral layer are in attachment with each other, but there is a thin film of a fluid in between them, which is called peritoneal fluid. So the potential cavity between the parietal and visceral layer is called peritoneal cavity, which is containing thin amount of fluid. This fluid allows movement of the different organs on each other and on the walls of the abdomen. This peritoneal cavity between the parietal and visceral layer of peritoneum is said in female to be open to exterior. Why is that? Just look to this diagram. In this diagram, the vagina is open to exterior, and the cavity of the vagina is open to the cavity of the uterus, and the cavity of the uterus is opened to the cavity of uterine tube, and the uterine tube laterally is opened into the pelvic peritoneal cavity. And therefore, in female, the pelvic peritoneal cavity is connected by this pathway to exterior. So the peritoneal cavity in female is opened, and such an opening is not available in male peritoneal cavity. Again, if we are looking to this sagittal diagram, you may see that the peritoneal cavity, which is between the parietal and serous layer of peritoneum, could be divided as two regions. This region is the cavity that is located behind the liver and behind the stomach and behind a fold of peritoneum called lesser omentum that extends between the liver and the stomach. So the part of peritoneal cavity behind the liver, behind the fold of lesser omentum, and behind the stomach, this part of peritoneal cavity is called lesser sac, also called omental bursa. Other parts of the peritoneal cavity, which are drawn here in black, is called greater sac, and both the lesser sac and the greater sac are continuing with each other by a small space or opening called epiploic foramen that will be studied soon. Classical study of the peritoneal anatomy is usually started by tracing a drawing of the peritoneum in sagittal section. You can see here that the anterior abdominal wall is lined by parietal peritoneum in this drawing, and the parietal peritoneum continues to the under surface of the diaphragm. This is also parietal peritoneum lining the diaphragm. And also here, the posterior abdominal wall and the vertebrae is covered by parietal peritoneum. This point of the parietal peritoneum and that point of parietal peritoneum reflected to the liver. And so now the peritoneum is visceral. The visceral peritoneum surrounds the liver completely, and therefore the liver is considered as intraperitoneal organ. The term intraperitoneal organ refers to the organ that is surrounded by the visceral peritoneum. It does not refer to the organ in the peritoneal cavity. There is no organ in the peritoneal cavity. The peritoneal cavity is a potential cavity containing thin amount of fluid, but intraperitoneal organ are organ that is surrounded nearly completely by visceral peritoneum. So following the parietal peritoneum to this point and that point is followed by reflection of the peritoneum from parietal to visceral layer of peritoneum covering the liver. Then the visceral peritoneum extends between the liver and the stomach, and this extension form the so-called lesser omentum. Then the visceral peritoneum surround the stomach, and therefore the stomach is called intraperitoneal organ. After that, the peritoneum extends down and ascend up to form a fold, which is called the greater omentum, so as to name the fold above the stomach lesser omentum, while the fold below the stomach greater omentum. Then the greater omentum, as you can see, as it is folded, is considered to be formed of 4 layers, 1, 2, 1, 2, or it is 2 folds that are folded. After being folded, the greater omentum surround the transverse colon. So the transverse colon is an intraperitoneal organ, and then there is an extension from the transverse colon of peritoneum, which is visceral peritoneum, and here this piece is called transverse mesocolon. The transverse mesocolon reaches the posterior abdominal wall on the anterior aspect of the pancreas. This is the pancreas. So the 2 layers of the visceral peritoneum, one of them continue with the posterior peritoneum, parietal peritoneum on the posterior abdominal wall, and the other also continue with the parietal peritoneum on the posterior abdominal wall, just like that. This reflection will be on the front of the pancreas. Thus the pancreas here is a retroperitoneal organ. Similarly, this is the duodenum below the pancreas, which is a retroperitoneal organ because it lies behind the parietal peritoneum. Also the pancreas lies behind the parietal peritoneum. And then the parietal peritoneum extends down to this point, and we have also parietal peritoneum from there covering the vertebrae. The 2 parietal peritoneum meet there to form a visceral peritoneum that surround the small intestine, and this fold of peritoneum surrounding the small intestine is called mesentery of small intestine. And if you follow this parietal peritoneum, you will reach the rectum. The upper 2/3 of the rectum is covered anteriorly by peritoneum. Then the peritoneum covers the back of the upper vagina, and then the peritoneum, which is of course a visceral peritoneum, then the peritoneum covers the back of the uterus and most of the part of the front of the uterus, and then it is refracted on the superior surface of the urinary bladder and coming in continuity with the beginning, which is the parietal peritoneum of the anterior abdominal wall. And you can see that this cavity is the lesser sac or omental bursae, which is the cavity behind the liver, behind the stomach, and behind the fold of lesser omentum, while all the other cavity is the greater sac. Also, classical teaching of peritoneal anatomy not only considered the sagittal section drawing, also we may do a transverse section drawing to study the peritoneum. Again, this is the parietal peritoneum on the anterior abdominal wall in transverse section at the level of the stomach. Actually, it is at the level of L1 vertebra or T12 vertebra. Then the parietal peritoneum is reflected to the posterior abdominal wall. Also, we have here parietal peritoneum of the posterior abdominal wall. This parietal peritoneum and that parietal peritoneum extends to the spleen, and thus it extends between the kidney. Now you can see that the kidney lie behind the parietal peritoneum, and so it is called retroperitoneal organ here. Then the 2 parietal peritoneum, this one and that one, form a fold that extends to the spleen. This fold is called splenorenal ligament because it is between the spleen and the kidney, splenorenal. Sometimes it is called lienorenal. Lieno means spleen. So this is a fold which is called splenorenal ligament, and you can see that this fold surrounds the spleen. Thus, the spleen is intraperitoneal organ surrounded by visceral peritoneum. Then, from the hilum of the spleen, there is another fold. It extends to the stomach in form of another ligament, which is called gastrosplenic ligament, that is between the spleen and the stomach. And also then the peritoneum surrounds the stomach, and from the stomach there is a lesser omentum, and you can see that the lesser omentum has a free border. There is a space between below the or deep to the free border of lesser omentum. This is the lesser omentum. All of this is the lesser omentum, and this space between the free border of the lesser omentum and the parietal peritoneum on the posterior abdominal wall is called omental foramen or epiploic foramen of Winslow or omental foramen of Winslow, in which the space behind the stomach and behind the lesser omentum, which is lesser sac, gains or obtained continuity with the other space of peritoneum, which is the greater sac, via this region, the region behind the free border of lesser omentum, which is called omental foramina or epiploic foramina of Winslow. You can see here that the kidneys, the right and left kidneys, are retroperitoneal organs. Inferior vena cava and the aorta are retroperitoneal organs, and by that you had finished studying transverse and sagittal section into the peritoneum, which is a way of classic teaching of the peritoneum. And we said that this transverse section is available of T12 or L1. T12, mostly it is at T12. So, from the drawing of sagittal and transverse section, I had mentioned some names: mesentery, omentum, and ligament, which are, all of these names are folds of peritoneum. So generally, in the terminology for the peritoneum, suggesting that folds of the peritoneum could be called as either mesentery if the folds suspend intestine, whether small intestine or large intestine. The other fold may be called as omentum if it suspends the stomach. Any other fold of peritoneum that is neither suspending the intestine or suspending the stomach is called ligament of peritoneum. It's not like the ligament of the joints, it's a fold of peritoneum. So folds of the peritoneum are mesentery if suspending small or large intestine. Folds of peritoneum are omenta if they are suspending the stomach, and any other folds other than these, they are called ligament. And I think if you'll go back, for example, here, this is a fold suspending the stomach, so it is a lesser omentum. And also here, a fold above the stomach is called lesser omentum, and a fold below the stomach is greater omentum. This is a fold that suspends the small intestine, it is a mesentery of small intestine. And this is a fold that suspends the transverse colon, it is mesentery of a transverse colon, or called transverse mesocolon. Also here you may see that this is a fold suspending the spleen, so it is called ligament, splenorenal ligament and gastrosplenic ligament. So this is a figure for the mesentery fold of the small intestine, and this is a mesentery of the large intestine. This is the mesentery of the transverse mesocolon, called transverse mesocolon. This is the mesentery of the sigmoid mesocolon, called sigmoid mesentery, which is called sigmoid mesocolon. And this is the mesentery of the appendix, which is called appendicular mesocolon. Again, the stomach, and above it is a fold, and below it is a fold of peritoneum. They are called omenta. The superior omenta is between the stomach and liver. This is called lesser omentum, while the inferior omentum is the greater omentum because this is larger in size, covering all the intestine deep to it. And otherwise you have gastrosplenic and lienorenal ligament as folds of peritoneum. So another terminology used is the term intraperitoneal organ. As I said, it includes any organ that's completely surrounded by peritoneum. It does not, an intraperitoneal organ is not an organ in the peritoneal cavity. The peritoneal cavity contains no organ. It's only contain a thin amount of fluid, and it is a potential cavity. While retroperitoneal organ, for example, the descending, ascending colon, the kidney in this figure, we said that kidney, inferior vena cava, aorta, and the other kidney, all of these are retroperitoneal because here the referral is for retroperitoneal organ lying behind the parietal peritoneum, covered by peritoneum, and including also the pancreas. Duodenum also are retroperitoneal organs. So from that terminology, we may pass into details of each of these folds, the mesentery, the omentum, the ligaments. Starting with the greater omentum. You know what is the greater omentum? It is the fold below the stomach. Above the stomach is the lesser omentum. The greater omentum is the fold below the lower border of the stomach. This lower border of the stomach is called the greater curvature of the stomach. And as you can see, it covers the intestine, and it is made of 2 layers that is folded, therefore it is made of 4 layers. So just look to the folding of the 2 layers here. The first will become fourth, the second will become third. Just look to these third and fourth layer. They extend up to be attached to the anterior aspect of the pancreas. And from the anterior aspect of the pancreas, this is the mesentery for the transverse colon, which is called transverse mesocolon. And therefore you can see here that we have a circle around the greater omentum, the third and fourth layer of greater omentum, and the 2 layers of transverse mesocolon, mesentery of transverse colon. Both are encircled, and the circle is crossed just like that. This is an indication in the drawing that the third and fourth layer of transverse mesocolon will be fused with the mesentery of transverse colon. The third and fourth layers of the greater omentum will be fused with the mesentery of transverse mesocolon, forming not 4 layers but 2 layers. And I will show you the figure that I had just demonstrated to you. Remember this. I will pass to the other figure. Look here. This is the greater omentum below the stomach. It is folded. It surrounds the transverse mesocolon, and here we don't have 4 layers. We have only 2 layers because the 4 layers fuse to form 2 layers, and the 2 layers are attached to the pancreas, to the anterior aspect of the pancreas. So what is important here that you may have to describe attachment of the greater omentum. You will say that the greater omentum is attached anteriorly to the lower border of the stomach, which is called the greater curvature of the stomach. But the greater omentum is attached posteriorly to the pancreas. And also you will find that when we will talk about the mesentery of a transverse colon, we will say also that the transverse mesocolon also attached to the anterior aspect of the pancreas. And the reason of that, because these 2 layers will fuse together. So attachment of the greater omentum anteriorly to the greater curvature, which is lower border of the stomach, while posteriorly the greater omentum is attached to the anterior aspect of the pancreas. This is the greater omentum. You can see it is loaded with fat, containing blood vessels. So if you open the greater omentum by scissor or scalpel at the lower border of the stomach, which is called the greater curvature. You will find here vessels that are called gastroepiploic vessels running there. So content of the greater omentum includes number one, left and right gastroepiploic vessels. Gastroepiploic, the name gastroepiploic, because these vessels give branches to the stomach, which are gastric, and the branches to the greater omentum, which are epiploic. So the original stem is called gastroepiploic, left and right, running at the greater curvature of the stomach. In addition to that, any of the folds that will be described soon, you will have to add to the content fat, autonomic nerves, and lymphatics. So the main content of the greater omentum is the left and right gastroepiploic vessels, but you have to say in addition fat, autonomic nerves, and lymphatics. And actually the fat is much in the greater omentum. The greater omentum is called the policeman of the abdomen. Why? You can see that the greater omentum is forming a large cover or apron to the intestine. Sometimes if you have, for example, infected appendix, appendicitis, the greater omentum will deviate to catch the inflamed appendix, just like a policeman. And thus, it will surround the appendix and preventing the pus of inflamed appendix from spreading to the other regions of the abdomen. And that's why it is a policeman of abdomen, to prevent spread of infection, for example, into the appendix to other regions of the abdomen. Or sometimes there may be a perforated peptic ulcer, gastric ulcer. So because of perforation, contents of the stomach will leak out to fill the peritoneal cavity. So also the apron of policeman of greater omentum will deviate up to close the opening of the perforated ulcer, and that's why it is a policeman of abdomen. In addition to that, the greater omentum serves in storage of fat and other functions. This is all about the greater omentum. Attachment, definition, and content and function. Lesser omentum. You know that the fold between the liver and the stomach is called lesser omentum. It is attached superiorly to the liver, specifically to the porta hepatis, which is the hilum of the liver, and the fissure for ligamentum venosum. While attachment below is to the upper border of the stomach, which is called lesser curvature, and also to the first 2 centimeters of the duodenum, which is the first part of duodenum. That's why the lesser omentum is divided for descriptive purposes into 2 parts. That between the liver and the stomach is called hepatogastric part, and that between the liver and duodenum is called hepatoduodenal part. And you can see that the lesser omentum has a free border on the right side, and you can see that there is a space behind this free border. And we said that this free border is the space, or deep to this free border is the space connecting the greater sac of peritoneal cavity with the lesser sac, which is the cavity between the liver, lesser omentum, and the stomach. You can see in the figure that the lesser cavity is the cavity behind the stomach, behind the lesser omentum, and behind the liver, behind the lesser omentum, and behind the stomach. This cavity, the lesser sac, continues with the greater sac via the space behind the right free border of lesser omentum, which is called epiploic foramen of Hounslow or omental foramen. Contents. Also, if you have a scissor and open the lesser curvature of the stomach, you will find vessels here which are gastric, right and left gastric vessels. With them there will be right and left gastric nerves. Gastric nerves are actually vagal nerves. Vagal nerves enters the thorax with the esophagus, but later on they will be running there along the lesser curvature of the stomach with the gastric arteries. And so content of the lesser omentum are the lesser curvature are right and left gastric nerves and anterior and posterior, left, right, and left gastric vessels and anterior and posterior gastric nerves, while contents at the free border, you know the free border, the right free border of lesser omentum, content at the free border are the bile duct, hepatic artery, and portal vein. You can see that here at the free border of lesser omentum, the portal vein is posteriorly, and anterior to it are the bile duct and hepatic artery. The bile duct is on the right side and the hepatic artery is on the left side, and both of them are anterior to the portal vein. In addition to here the three structures, which are bile duct, hepatic artery, portal vein, and the free border, and the right and left gastric vessels, anterior and posterior gastric nerves, and the lesser curvature, you can add content of the lesser omentum, including fat, autonomic nerves, and lymphatics. Look to this question mark: gallstones in the gallbladder, in the bile duct. Sometimes you have gallstones in the gallbladder, and these are maybe small stones that may enter the bile duct, and so you need to have an operation to evacuate the bile duct from stones. So you have only to open the margin of the lesser omentum from right side, and when you will open the margin of the right side of the lesser omentum, you will directly see the bile duct and get the stone out of it. What about the anatomy of the mesentery of small intestine? The term small intestine refers to the duodenum, then the jejunum, then the ileum, which is opened into the cecum. But fortunately, the duodenum is a retroperitoneal organ. It does not have a mesentery. The mesentery of a small intestine is a fan-shaped fold of peritoneum that suspend only the jejunum and ileum parts of the small intestine. And as you can see that the jejunum and ileum are suspended, movable parts. Therefore, this figure also shows the configuration of the mesentery of small intestine. That peritoneum from the posterior abdominal wall descends around the small intestine and returns back to the posterior abdominal wall. Therefore, the mesentery has a free border that contains the intestine, which is an intraperitoneal organ, and an attached border. This attached border of the mesentery of small intestine is called the root of the mesentery of small intestine. So here there is a free border, which is visceral peritoneum of the small intestine, and attached border, which is the root. So you have to follow where does this root is attached. The root attachment start from the duodenojejunal junction between the duodenum and jejunum, which is at the level of L2. Then the root of attachment of the mesentery occurs on the third part of duodenum, and here it contains the superior mesenteric vessels to enter this root, and then the root will crosses the aorta and inferior vena cava and crossing the right ureter, right psoas muscle, and reaching the right sacroiliac joint to end at the junction of the ileum with the cecum. This is the line of attachment of the root of mesentery. If you remember what is meant by line of attachment, this is the region here where the root of mesentery is attached to posterior abdominal wall. You can see here in this sagittal section, this root is attached to the duodenum, for example. And actually this is seen here. You can see here that the root is attached to the duodenum, the same of that figure. But if you descend more downward and to the right, it will be descendants with the aorta, inferior vena cava, psoas, and so on. So these structures that enumerated here. The root of mesentery, as it crosses the third part of duodenum, at this region, vessel, which is a branch from the aorta, called superior mesenteric artery, enters the root of mesentery. So the content of the mesentery of small intestine is the superior mesenteric artery with its branches to the jejunum and ileum. And also we have fat, autonomic nerves, and lymphatics. The mesentery of appendix is a very small triangular fold suspending the appendix. It is attached to the root of mesentery of small intestine near the ileocecal junction, and it contains vessels and nerves to the appendix, in addition to fat, autonomic nerves, and lymphatics. You remember the circle and the cross. Mesentery of transverse colon also has a free border and attached root. The root is to the anterior aspect of the pancreas. You can see that because the transverse colon and the transverse mesocolon, which is mesentery of the transverse colon, fuse with the greater omentum. If you elevate the greater omentum above, just like in this figure, you will find that the transverse colon is attached to the inner aspect of the greater omentum. This is the greater omentum from inner side or for posterior aspect. The greater omentum is reflected upward, and when you reflect it, you will find that the transverse colon is attached to it posteriorly, and here this is the region of the transverse mesocolon. And therefore the attachment of the root of the transverse mesocolon is to the pancreas, the same as the attachment of the greater omentum posteriorly. Content of the greater omentum is middle colic branch of superior mesenteric artery together with fat, autonomic nerves, and lymphatics. Mesentery of the sigmoid colon is triangular fold of peritoneum that has a free border also. It's suspended by a root which is attached in a form of inverted figure V. This attachment is by left limb, right limb, and an apex. The left limb is to the external iliac vessels. The right limb is to the sacrum. The apex is on the ureter at the bifurcation of the common iliac artery. Contents of the sigmoid mesentery, sigmoid mesocolon, is superior rectal vessel, which is the termination of inferior epigastric artery, in addition to fat, autonomic nerves, and lymphatics. In consideration to peritoneal folds forming ligaments, we have peritoneal folds suspending the liver. The liver is suspended to the anterior abdominal wall and to the diaphragm and posterior abdominal wall. And this drawing for the attachment of the peritoneum of the liver, or reflections of the peritoneum of the liver, which is visceral peritoneum, to the posterior abdominal wall and to the peritoneum of the diaphragm. You can see that these reflections form a left and right triangular ligament, a superior and inferior coronary ligament. These left and right triangular ligaments, superior and inferior coronary ligaments, suspend the liver to the diaphragm. This is the superior coronary, this is the inferior coronary, this is the left triangular, and that is the right triangular. All of them suspend the liver to the diaphragm. But anteriorly, the liver is suspended by double fold of peritoneum, which is called falciform ligament. This falciform ligament suspends the anterior aspect of the liver to anterior abdominal wall, and also the superior aspect of the liver to the diaphragm. The falciform ligament has a lower border, which is called ligamentum teres, or round ligament of the liver, that represents the obliterated umbilical vein. So falciform ligament is a sickle shape fold extend from the anterior superior surface of the liver to the anterior abdominal wall and the diaphragm. And this is the talk about the vein, which is obliterated at the lower border of the falciform ligament and is called round ligament or ligamentum teres. Ligament of the spleen are simply the lienorenal or splenorenal and gastrosplenic ligaments. And the lienorenal contains splenic artery, while the gastrosplenic contain branches from the splenic artery to the stomach, which are called short gastric vessels. So in addition to fat, autonomic nerves, and lymphatics, the splenorenal ligament contain splenic vessels, and the gastrosplenic ligament contain branches from the splenic vessels that are called short gastric vessels as they are going to the stomach. Phrenicocholic ligament. You know, this is the transverse colon, and this is the ascending colon, and this is the descending colon. The angle between the ascending and the transverse colon is called right hepatic flexure of colon, while this angle between the transverse colon and descending colon is called left splenic flexure of transverse colon. And from the left splenic flexure of transverse colon, there is a fold of peritoneum to the diaphragm, which is called the phrenicocholic ligament. It is very important, as a very important clinical application. Regarding the epiploic foramen or omental foramen, which is the space deep to the right free border of lesser omentum. This epiploic foramen, we said that it is the space connecting the lesser sac, which is behind the liver, lesser omentum, and the stomach, with the greater sac. The space deep to the right free border of the lesser omentum is the epiploic foramen of Winslow. This foramen lies at the level of T12 vertebra. It is bounded anteriorly by the lesser omentum, superiorly by the liver, specifically the caudate process of the liver, and inferiorly the duodenum, while posteriorly it is bounded by the gland above the kidney, which is called the right suprarenal gland, and also inferior vena cava. The lesser sac, which is the space behind the liver, behind the lesser omentum, and behind the stomach. Therefore, it is bounded by the stomach anteriorly, and by the lesser omentum anteriorly, and by the liver anteriorly, mostly, or specifically the caudate lobe of the liver. While the lesser sac or the omental bursa is bounded posteriorly by the structures forming the so-called stomach bed. That includes the pancreas, transverse mesocolon, left kidney, left suprarenal gland, spleen, and diaphragm. The lesser sac, or the omental bursa, is described to have three recesses. The recess behind the stomach is called the inferior recess, while the recess behind the liver and lesser omentum is called superior recess. And inside this superior recess, the space behind the lesser omentum only is called vestibule of the superior recess, or vestibule of the omental bursa or lesser sac. And the space behind the gastrosplenic and lienorenal ligament is called splenic recess of lesser sac or omental bursa. Another way of a classification to the peritoneal cavity other than greater sac and lower sac is the following. The attachment of transverse colon and the transverse mesocolon to the anterior aspect of the pancreas, as you can see here, This is the root of transverse mesocolon. It is to the anterior aspect of the pancreas. This is the duodenum, and the pancreas lies in the C or the duodenum. So you can see that the root of transverse colon is attached to the anterior aspect of the pancreas. This attachment divides the peritoneal cavity into another method of classification other than the greater sac and lesser sac, into a cavity above the transverse colon and transverse mesocolon, which is called supracolic compartment, and the cavity below the transverse colon and transverse mesocolon, which is infracolic compartment. Supracolic and infracolic, above and below the transverse colon and transverse mesocolon. And the supracolic compartment divides by the ligaments suspending the liver, peritoneal ligaments suspending the liver, which are left triangular ligament, right triangular ligament, superior coronary and inferior coronary and falciform ligament. These ligaments suspending the livers divides, for description, the supracolic compartment into spaces around the liver which are below the diaphragm, and thus they are called subphrenic spaces because these are below the liver. They are anterior right and anterior left subphrenic space, and posterior right and posterior left subphrenic space. The posterior right and posterior left subphrenic spaces are also called subhepatic because they lies below the liver. So either you can say right posterior subphrenic space, or you can say right subhepatic space. Also, you can call this region left posterior subphrenic space or left subhepatic space, and you can see clearly that this left subhepatic space or left posterior subphrenic space is the same of the lesser sac, which is omental bursa. So this region has four names: either omental bursa or lesser sac, or left posterior subphrenic space or left subhepatic space. Also, the root or the attachment of mesentery of small intestine divides the infracolic compartment into right and left infracolic compartments. You can see here that the right infracolic compartment is triangular with the apex down, the base up, and this right infracolic compartment or space is bounded medially by root of small intestine, laterally by ascending colon, and superiorly by root of transverse colon. While the left infracolic compartment is rather quadrilateral, it is bounded superiorly by root of transverse colon, laterally by the descending colon, medially by root of small intestine mesentery, while inferiorly the left infracolic compartment, which is a quadrilateral, it is opened inferiorly into the pelvis. And also, according with this classification, the spaces lateral to the ascending colon and descending colon. This is the space lateral to the ascending colon, and this is the space lateral to the descending colon, are called paracolic gutters. This is the right paracolic gutter, and this is the left paracolic gutter. You can see that the left paracolic gutter is opened inferiorly into the pelvis, but superiorly it is stopped by the phrenicocholic ligament that extends between the splenic flexure of the colon and the diaphragm. While the right paracolic gutter extends inferiorly into the pelvis, and it extends superiorly to the left posterior subphrenic space, or called left subhepatic space, and actually this space is sometimes called hepatorenal space or pouch of Rutherford Morrison, and we will repeat that in the following figures, but just look to the same explanation in the figure above. Here is the root of mesentery of small intestine, dividing the space below the transverse colon, which is infracolic compartment, into a triangular left and quadrilateral right. The quadrilateral right is opened inferiorly to the pelvis. This is the left paracolic gutter that is opened inferiorly into the pelvis. Superiorly, it is stopped here by the phrenicocholic ligament, while the right paracolic gutter extends inferiorly with the pelvis, but above it extends into the right subhepatic space or right posterior subphrenic space. You can see also here that the liver ligament classify the supracolic compartment into 4 subphrenic spaces. This is a right anterior subphrenic space between the liver and the diaphragm. This is the left anterior subphrenic space between the diaphragm and left lobe of liver. This is the right subhepatic space, or called right posterior subphrenic space, or called hepatorenal pouch of Rutherford Morrison, while this is the left posterior subphrenic space, or called left subhepatic space, or called omental bursa, or called lesser sac. So we will discuss these in details. First, the left anterior subphrenic space is between the diaphragm and right lobe of liver, limited above by the superior coronary ligament. You can imagine from this figure, this space is limited above by the right coronary ligament. This is superior coronary ligament. This is the superior coronary. This is inferior coronary. This is right triangular. This is left triangular. So this space, which is the right anterior subphrenic space, is limited by the superior coronary ligament, which is a fold from the liver to the diaphragm. So this is the left anterior subphrenic space between the diaphragm and right lobe of liver, limited above by the superior coronary ligament and by the right triangular ligament, while the left anterior subphrenic space between the diaphragm and left lobe of liver is limited by the left triangular ligament. Below the liver here and there are the subphrenic spaces, which are posterior, right posterior subphrenic and left posterior subphrenic, or called right subhepatic and left subhepatic. The left subhepatic is the lesser sac, while the right subhepatic is the hepatorenal Rutherford Morrison pouch. So the right subhepatic, now we are removing the liver lobe, the right lobe. This is the right subhepatic space. It is Rutherford Morrison space, limited anteriorly or superficially by the root lobe of liver and gallbladder, while deep or posteriorly it is called hepatorenal. So anteriorly is the liver, posteriorly is kidney, which is the right kidney, right suprarenal, and also you can see posteriorly is the duodenum, which is second part of duodenum, and transverse colon. All of these are posterior boundary of the right posterior subphrenic space or right subhepatic space, or called hepatorenal pouch, Rutherford Morrison pouch. We will not talk about the left posterior subphrenic space or left subhepatic space or lesser sac, because we had discussed it soon before a while in the previous start. But I have to say that this pouch, the Rutherford Morrison pouch, is the most dependent position in the peritoneal cavity when the patient is lying supine. This is important. Why? Suggests that there is an infection into the peritoneal cavity from appendix or ruptured peptic ulcer of the stomach. The pus from the infection would spread into the peritoneal cavity, and when the patient is lying supine on the surgical bed, for example, you have to clean the hepatorenal pouch when the patient is lying supine by a sucker, because all the pus and secretions from perforated stomach or from infected appendix will be collected in the hepatorenal pouch when the patient is supine, because this hepatorenal pouch is the most dependent position in the peritoneal cavity when the patient is supine. Well, if the patient is semi-supine, the pus will be collected in the pelvis. Here, you know that the peritoneum covers the the upper two-thirds of the rectum from the anterior aspect, and then it will be reflexed to the vagina and the uterus. So this reflection is called rectouterine pouch of Douglas. It is the most dependent when the patient is semi-supine position, and thus infection, if you want to evacuate it and the patient is semi-supine, you have to evacuate it in the hepatorenal pouch, which is this one between the rectum and the uterus and vagina, for example by introducing a catheter from the vagina to this pouch and evacuating the pus here. This pouch in male is called rectovesical pouch because the peritoneum in male also covers the upper two-thirds of the rectum anteriorly, but it is reflected on the seminal vesicles and the back of the bladder and superior surface of the bladder, but still this pouch is most dependent in male, but is called rectovesical pouch, not rectouterine pouch, which is pouch of Douglas. This is only rectovesical pouch. This is the description for the infracolic compartment, which is right triangular, left quadrilateral. The left quadrilateral is opened inferiorly. Both are parts of the infracolic compartment, dividing by the root or attachment of mesentery of small intestine. This is a description to the hepatorenal, to the paracolic gutters. You can see that the right paracolic gutter extends below to the pelvis, but up it may extend to the hepatorenal or Rutherford-Morrison pouch, according to this figure again. Well, this is an important point to be remembered in the peritoneum. Sometimes you may find, not always, sometimes you may find inconstant pockets in the peritoneal cavity produced by inconstant folds. That these pockets are called peritoneal recesses. For example, you may have peritoneal recesses near the duodenum, or near the cecum, or near the sigmoid colon. These pockets, if they are present, may be pockets for invagination, abnormal invagination of a piece of intestine into it. And this when this piece of intestine passes into these pockets, the blood supply will be interrupted because it is a narrow pocket. So this is an internal herniation of the intestine. Cutting the blood supply will lead to strangulation and gangrene, and so it is very important to be remembered, because sometimes you will find a patient with acute abdominal pain opening this abdomen, and you will find that part of intestine is gangrene for no reason. This is because this part of intestine maybe had entered into one of these recesses, one of these pockets, has strangulated, the blood supply is strangulated and leading to gangrene. Finally, you have to remember the folds of the peritoneum on the back of the anterior abdominal wall, and I had revised these folds with the presentation of the anterior abdominal wall. And this is a transverse section at the level of the greater omentum, showing the mesentery of small intestine, showing the kidney, aorta, and inferior vena cava covered by parietal peritoneum, because all of these are retroperitoneal. These are the folds in the back of the anterior abdominal wall, the same of these folds, but are shown in section. And finally, the function of the peritoneum is to move the viscera, protect the viscera, and finally you have to say that the nerve supply of the peritoneum carry the rule, the same of the rule of the pleura, in which the parietal peritoneum is supplied by spinal nerve. Therefore, the pain of the parietal peritoneum is very severe, localized, where the visceral peritoneum follows the nerve supply of the viscera, and it is autonomic, thus it is pain insensitive. The parietal spinal nerves to the parietal peritoneum includes the phrenic nerve, which is for the peritoneum of the undersurface of diaphragm, intercostal nerves, first lumbar nerve, and occipital nerves, as these nerves The phrenic is for the diaphragm. The intercostal and thoracic and lumbar is for the parietal peritoneum of the inferior abdominal wall. They are the same nerves of the inferior abdominal wall. The obturator is the same nerve of the pelvic wall. Thank you very much.